Welcome to this clinical masterclass on safe blood transfusion practices. Blood transfusion is one of the most critical, high-alert procedures you will perform as a healthcare professional. It is a life-saving intervention, but it carries profound risks if executed without absolute precision. Our core philosophy is simple: safe transfusion, save lives. To achieve this, we must always ensure the four pillars of safety: the right blood goes to the right patient, at the right time, administered in the right way. As we look at the clinical scene before us, remember this golden rule: it is never just a bag of fluid hanging on an 4-pole, it is a living, cellular transplant. It is someone's life. To prevent catastrophic errors, you must commit the 6 rights of blood transfusion to memory. First, the right patient. Confirm their identity using at least 2 independent identifiers. Second, the right blood. Verify that the donor unit matches the patient's ABO and RH type perfectly. Third, the right time. Ensure the blood is administered within the correct clinical window and completed within 4 hours. Fourth, the right route. Use the correct intravenous access line and standard blood filter tubing. Fifth, the right reason. Verify the clinical indication for the transfusion. And sixth, the right documentation. Record everything immediately and accurately. These 6 checks are your primary line of defense. Why do we transfuse? Transfusions are clinical interventions driven by specific pathological deficits. First, acute blood loss, which frequently occurs in trauma, major surgeries, gastrointestinal bleeding, or obstetric hemorrhages. In these emergencies, we need to rapidly restore intravascular volume and oxygen carrying capacity. Second, we have chronic anemia and symptomatic anemia, where the patient's red blood cell count or hemoglobin levels are insufficient to support tissue oxygenation. Third, malignancy and chemotherapy often suppress bone marrow function, requiring support. Fourth, thrombocytopenia, where a low platelet count puts the patient at extreme risk of spontaneous bleeding. Fifth, coagulopathies or bleeding disorders where clotting factors are missing. We also perform exchange transfusions to swap out abnormal blood and provide support during severe burns, shock, and major surgeries to stabilize hemodynamics. Modern medicine rarely uses whole blood. Instead, we practice component therapy, giving patients only what they need. Packed red blood cells, or PRBCs, are concentrated red cells used primarily to increase oxygen carrying capacity in anemic patients. Platelets are essential for establishing a primary hemostatic plug to control or prevent bleeding. Fresh frozen plasma, or FFP, is the liquid portion of blood stored frozen to preserve active clotting factors. Cryoprecipitate is derived from FFP and is highly concentrated with specific proteins, fibrinogen, factor VIII, and von Willebrand factor. Finally, whole blood contains all cellular and liquid components, typically reserved for massive military or trauma resuscitations. Understanding ABO and RH compatibility is vital to prevent life-threatening immunological reactions. Let's look at the matrix. Type O negative is the universal donor. Because it lacks A, B, and RH antigens, it can be donated to all blood types. Conversely, type AB positive contains no anti-A, anti-B, or anti-RH antibodies, making them the universal recipients, though they can only donate to other AB positive individuals. O positive can donate to all positive types. A negative can donate to all A and AB types, while A positive is restricted to A positive and AB positive. The same rule follows for B negative and B positive. Memorize this chart, but remember the golden clinical safety rule shown at the bottom: when in doubt, go group specific to ensure absolute compatibility. Before any blood touches your patient, you must complete the pre-transfusion checklist. This is a non-negotiable safety sequence. Step 1. Verify the medical order. Step 2. Explain the procedure thoroughly to your patient. Step 3. Obtain and verify signed informed consent. Step 4. Check the patient's identity using at least 2 independent identifiers, like their full name and date of birth. Step 5. Verify the blood unit and its label directly at the bedside with the patient. Step 6. Perform hand hygiene to prevent infection. Step 7. Check the patient's vital signs and complete a baseline assessment. And Step 8. Ensure you have patent, large bore for access, ideally an 18-gauge catheter, or as clinically ordered. Let's look at the science of compatibility testing and the absolute contraindications. Prior to release, the blood bank performs ABO and Rh typing, an antibody screen to find atypical antibodies, and a major crossmatch to physically mix donor cells with recipient serum. As the nurse, you must check the expiry date and inspect the physical bag for any clots, signs of hemolysis, discoloration, or leaks. If there is any doubt, do not transfuse, clarify and confirm. We must also respect the contraindications: active patient refusal, lack of a valid clinical indication, an uncorrected identification mismatch, improperly labeled blood, expired blood units, active uncontrolled infection, or a documented history of severe transfusion reactions. Now, let's walk through the actual clinical administration. Step 1. Start. Check the patient's baseline vital signs. Once the blood is issued from the blood bank, you must initiate the transfusion within 30 minutes. Step 2. Identify. Bring the patient and blood unit together at the bedside for a rigorous double check. Step 3. Inspect. Look closely at the bag for physical abnormalities. Step 4. Start slow. This is critical. Infuse at a rate of 2 ml per minute for the first 15 minutes, and you must stay in the room with the patient. Step 5. Monitor. Check vitals at the 15-minute mark, and then continue monitoring as dictated by your facility's policy. Step 6. Complete. Once the unit is empty, flush the line with normal saline and dispose of the bag safely. Remember, one patient, one unit, one time. Vigilant monitoring saves lives. You must assess and document 5 specific vital signs: temperature, pulse, respiration rate, blood pressure, and oxygen saturation. These must be taken at 4 designated times: baseline, 15 minutes after starting, every 30 minutes to an hour during the transfusion, and immediately at completion. Even after the transfusion finishes, you must observe your patient for at least 1 hour. Be alert for any clinical changes. Specifically monitor for fever, chills, skin rashes, breathlessness, lower back pain, which indicates an acute hemolytic reaction, hypertension, or a sudden, unexplained onset of anxiety. If you suspect a reaction, you must act instantly. First, an acute hemolytic reaction presents with fever, chills, back pain, hypertension, and red urine. You must stop the transfusion immediately, notify the provider, and maintain for access with normal saline. Second, a febrile non-hemolytic reaction presents with fever and chills, stop the transfusion, notify, and administer antipyretics. Third, mild allergic reactions cause rash, itching, and hives, stop the infusion and give antihistamines. Fourth, anaphylaxis is a medical emergency with bronchospasm, hypertension, and shock, stop the transfusion, administer epinephrine, and provide immediate emergency care. Fifth, TRALI, or transfusion-related acute lung injury, causes severe dyspnea and hypoxemia, stop the transfusion, provide oxygen, and offer supportive care. Sixth, TUCO, transfusion-associated circulatory overload, causes dyspnea, hypertension, and pulmonary edema, stop the transfusion, sit the patient upright, administer oxygen, and give diuretics. Remember, when in doubt, think reaction. Let's review our clinical rules of thumb, starting with our quick facts. Always use standard blood tubing containing an integrated filter. Never add medications directly to a blood bag, and do not co-infuse other 4 fluids through the same line. If a blood unit goes unused, never return it to a standard clinical refrigerator, it must go straight back to the blood bank. Let's look at our nursing pearls. Always double verify your orders, stay with the patient for the first crucial 15 minutes, and document everything meticulously to protect both yourself and your patient. Every detail must be written down, including the clinical indication, blood group, exact start and stop times, vital sign trends, and your signature. Blood transfusion is a profound clinical responsibility that blends biological science with strict clinical vigilance. By masterfully executing the protocols we have covered today, you serve as the ultimate shield for your patient. Remember, every drop counts. Be alert, be careful, and be the reason someone lives. Thank you for participating in this clinical masterclass. Stay safe, and keep saving lives.